Okay, so morning friends, I'm Dr. Sushant Soni and I'm the pathology faculty with the institute. So starting with the pathology questions discussions of grant test 179, starting with question 43, which was the first question for pathology. Now this says that this is a long question. This is a long question, so much English is written, not concerned. Forget everything. I just need to look at two words: 61-year male and the image is given. This could very well have been kept as a no history question. The minute you see this image, you see the presence of large cells. All these are the large cells, the ones I am showing with the arrow. Large cells, abundant cytoplasm, eccentric nucleus. These are the plasma cells, and this slide is full of plasma cells. It has at least approximately 80 to 85% plasma cells, making the diagnosis as multiple myeloma. Now let us have a look at the question. 61 male, it is favoring multiple myeloma. Next, has back pain for 5 months. Radiograph reveals lytic lesion of the vertebral bodies. Sputum culture is showing this and that. Bone marrow is given. Diagnosis multiple myeloma. So this can be a no history slide also. Which of the following is most likely to be present? Multiple myeloma, you very well know, is associated with M spike, monoclonal spike. So it is associated with hypergammaglobulinemia. Question 43, the answer is D, that is hypergammaglobulinemia. Hypergammaglobulinemia, because the diagnosis in the image was multiple myeloma. Next point, let us have a look at few points associated with multiple myeloma. First point, it is a plasma cell dyscrasia. That is, it shows increased number of plasma cells, plasma cell dyscrasia with crab features. Firstly, plasma cell dyscrasia with crab features, where crab stands for hypercalcemia, calcium is elevated, renal insufficiency, anemia, and lytic lesions in the bone. Anemia and bone lytic lesions. This is multiple myeloma. Now, should all the graph features be present? No. Any one of these is sufficient to call it as multiple myeloma. Next, the second criteria for making a diagnosis is, first was increased plasma cells with any one graph features. Second is plasma cells more than 60% in bone marrow. Plasma cells more than 60% even in absence of graph features. Even in absence of graph features. This second point has been added in the recent 2016 WHO classification, hence is important. Next point, you very well know the main cytokine associated with multiple myeloma, interleukin 6 overexpression. The whole pathogenesis of multiple myeloma is based on interleukin 6. Next, you again know that bone lytic lesions. Next, ALP. Please put a star on this. ALP is normal in multiple myeloma. This is because ALP is an enzyme of osteoblastic activity. Multiple myeloma is associated with osteolytic activity. So ALP is normal in multiple myeloma. Done. And of course it is associated with M spike. M stands for monoclonal spike. So it is associated with hypergammaglobulinemia. Next, this gets us to our next question, that is question 44. This gets us to Aschoff cells. I need not even tell you this. Aschoff cells, these are the monocytes. So question 44, the answer is B, that is monocytes. They are the monocytes. Let us have a look at RHD. First point, the microscopic diagnostic feature of rheumatic heart disease is the presence of Aschoff bodies. The microscopic diagnostic feature is Aschoff bodies. What are they? Aschoff bodies, these are focal distinctive inflammatory infiltrate. Focal distinctive inflammatory infiltrate in the heart. Distinctive focal inflammatory infiltrate in the heart. First point. Next, so it is composed of inflammatory cells. Which inflammatory cells? That is, it has macrophages, Aschoff giant cells, monocytes, that is the Aschoff cells, and Entishkov cells. So, which is the pathognomic feature? Which is the pathognomic feature of RHD, or the pathognomic cell is the Entishkov cell. The pathognomic cell of RHD is Entishkov cell, also called as caterpillar cells. This is because of its nuclear arrangement. It is the Entishkov cell or the caterpillar cell. Next point, most common valve affected, mitral valve. Acute RHD, mitral regurgitation. Chronic RHD, mitral stenosis. Because of that, it is chronic RHD, it is also associated with fish mouth appearance of the mitral valve, where it is, as the fish mouth is because of calcification and fibrosis. This is RHD. So before we go further, let us have a look at what it looks like microscopically. What we see here is the cardiac muscle. All this is the cardiac muscle. This is the cardiac muscle with presence of focal distinctive inflammatory infiltrate. What do I mean by distinctive? See, this inflammatory infiltrate, it is not going inside the muscles randomly. It is present focally distinctive inflammatory infiltrate, hence making the diagnosis as Aschoff bodies. Making the diagnosis as Aschoff bodies. Next, this gets us to our next question, that is question 45. This gets us to our next question, that is question number 45. Just a sec, let us have a look at the question. DVT, deep venous thrombosis, is a manifestation of Leiden mutation. The answer is B, that is Leiden mutation. The answer is B, Leiden mutation. Now let us have a look at this. Leiden mutation, firstly, this is the most common primary hypercoagulability. Primary or inherited factor 5 Leiden mutation, this is the most common cause of primary or inherited hypercoagulability. Inherited hypercoagulability. Next point, caused by mutations in factor 5. What occurs because of this? This is the most common cause of primary hypercoagulability. Because of this, the mutation alters an amino acid residue in factor 5. Mutation alters an amino acid residue. It alters an amino acid residue in factor 5. As a result of which this becomes resistant to protein C. As a result of which it becomes resistant to protein C. Protein C and protein S, they are important fibrinolytic pathways. So because of resistance to protein C, it is associated with primary hypercoagulability. Next point, this factor 5 Leiden mutation, it is also associated with increased risk. It is associated with increased risk of venous thrombosis. It is associated with increased risk of venous thrombosis. This is factor 5 Leiden mutation. The other causes of primary hypercoagulability are protein S deficiency, antithrombin 3 deficiency and stuff, which are even rarer. This is the most common cause. Next, this gets us to a next question, that is question 46. Now, what we have in this is 26 male, severe chest, abdominal pain, afebrile. Now, again, this can simply be a no history slide. You just have the image with you, there's nothing else, and this shows you the presence of sickle cells. Sickle cell anemia. Diagnosis, sickle cell anemia. I do not need other history or anything else to make a diagnosis. which is the condition he is most likely to be associated with? And the answer is C, that is pigmented gallstones. So question 46. Question 46. The diagnosis is sickle cell anemia. The diagnosis is sickle cell anemia, and the answer is C, that is pigmented gallstones. Pigmented gallstones. You very well know sickle cell anemia is a hemolytic anemia. Sickle cell, it is a hemolytic anemia, as a result of which it is associated with increased bilirubin. Hemolytic anemia, increased unconjugated bilirubin, in turn leading to gallstone formation. Gallstones are of two types. Most common is cholesterol stones, that is the 4Fs, fat fertile female 40, and the pigmented stones. I'll write it for you. Gallstones are of two types. Most common that are the cholesterol stones. When I say that most common, I mean approximately 90% are the cholesterol stones, and this is associated with 4Fs, fat fertile female 40, versus the other side is pigmented stones. Pigmented stones, which is associated with hemolytic anemias and infections. So the answer to question 46 is pigmented stones. Next, this gets us to our next question, that is question 47. This gets us to question 47. Germ cell tumors are all of the following except, again easy, answer is C, that is Brenner's tumor. Question 47, the answer is C, that is Brenner's tumor. Let us now have a look at germ cell tumors. Let us have a look at germ cell tumors of the ovary. I can divide the germ cell tumors into two types, that is the mature germ cell tumors, the mature or the teratomas, mature germ cell tumors or teratomas, versus the immature germ cell tumors. Mature and immature. Which are more common? Mature. How common? Approximately 95%. So the most common germ cell tumor of the ovary is a teratoma. Next point, all of you would have seen that gross of teratoma. It is that dirty gross specimen of hair, cheesy material and teeth which is extruding out. It has all ectoderm, mesoderm and endoderm. That is teratoma. Next point, immature germ cell tumors are again of two types. That is seminomas and non-seminomatous tumors. Seminomas and non-seminomatous tumors. First point, seminoma is the ovarian counterpart of seminoma is dysgerminoma. The ovarian counterpart of seminoma is dysgerminoma. Next point, non-seminomatous tumors are three, that is yolk sac tumor. They are three, that is yolk sac tumor, embryonal carcinoma, and choriocarcinoma. Yolk sac tumor, embryonal carcinoma and choriocarcinoma. These are the germ cell tumors of the ovary. So easy question, all of the following are germ cell tumors except, and the answer is Brenner's. Brenner's is a surface epithelial tumor. Brenner's tumor is a surface epithelial tumor. Next point, let us see one, two more questions here only. First question, best prognostic immature germ cell tumor, dysgerminoma. Best prognostic immature germ cell tumor, dysgerminoma. Worst prognostic immature germ cell tumor, choriocarcinoma. Worst prognosis, choriocarcinoma. Associated with increase in which tumor marker? Beta HCG. Beta HCG, human chorionic gonadotropin, beta HCG. Next point, Teratomas we have seen has all three layers, ectoderm, mesoderm, endoderm, but they can be monodermal also. So most common monodermal teratoma, most common monodermal teratoma is struma ovari. Most common monodermal teratoma, that is, it has a single layer, it shows the presence of thyroid in ovary, struma ovari. Next point, teratomas, they were the mature tumors, but they can undergo a malignant transformation also. So most common malignancy associated with teratomas, squamous cell carcinoma. most common malignancy most common malignancy with teratomas is squamous cell carcinoma. Squamous cell carcinoma. Done. This takes care of question 47. Sorry, that was a technical glitch. So this takes care of question 47. Next, this gets us to our next question, that is question 48. Question 48. Now, which of the following, irrespective of its maturity, is immature teratoma? Now, this gets us to our next question, that is question 48. Which of the following is immature irrespective of its maturity, of its elements? देखो बच्चे, teratomas or germ cell tumors, they occur in the younger population, that is in children. So ovarian teratoma in children is okay, testicular teratoma in children is okay. I'll not be bothered about these options. Testicular teratoma in postpubertal males. Now males, the most common testicular tumor is a germ cell tumor. 95% of testicular tumors are germ cell tumors, except in elderly where it is presumed to be a lymphoma. So I am not even worried about option 4. The answer is 3, that is ovarian teratoma in a postpubertal female. Question 48. The answer is C, that is ovarian teratoma. Ovarian teratoma in a postpubertal female. Ovarian teratoma in a postpubertal female. This is considered as an immature teratoma irrespective of its elements. C. Males, majority 95% testicular tumors with germ cell, not worried. Teratomas as such occur in children. So option A and B were out. So the answer is C. Next, this gets us to our next question, that is question 49. Now this is a good one. Relationship between HIV and CCR5 with homozygous mutation. Point to be noted here is that it is a homozygous mutation, and the answer is A, it is protective. The answer is A, that is, it is protected against HIV infection. It is protected against HIV. This was a good question. Let us have a look at this in more detail. Starting with pathogenesis of HIV. Now, you very well know HIV, it has two proteins, GP120, which is present outside on the envelope, and GP41, which is present embedded in the lipid matrix. First, the GP120 binds with CD4 and its co-receptors, as a result of which GP41 binds. So, let us now write this. Pathogenesis. Viral GP120, HIV virus GP120 binds to CD4 receptors. It binds to the CD4 receptors, as a result of which this leads to binding to co-receptor molecules. This leads to binding to co-receptor molecules. There are two co-receptor molecules, which are CCR5 and CXCR4. There are two co-receptors. CCR5 binding, this is by R5 strains of the virus, whereas CXCR4 binding is by the X4 strains of the virus. Next point, the R5 strains of the virus, are M-tropic. That is, they predominantly infect macrophages and monocytes. They are M-tropic. They predominantly infect macrophages and monocytes versus the X4 strains which are T-tropic versus the X4 strains which predominantly infect the T cells. Next point, let us see it here only. The R5 strains are more commonly associated with early infection versus the T-tropic strains which are more commonly associated with late infection versus the T-tropic which are with late infection. This is the basic pathogenesis of HIV. Once the cell virus enters into the cell, it binds with the host genome, undergoes reverse transcriptase activity, in turn leading to budding. Now, the point to be noted here is there is a homozygous mutation. Point to be noted is in case of homozygous mutation, in case of homozygous mutation, it is associated with protection against HIV. It is associated with protection against HIV. This is extremely rare. This mutation though is extremely rare. This is homozygous mutation. Next point, in heterozygous mutation. There is slow progression of the disease. In heterozygous mutation, the progression of HIV is slower. This is HIV. Next point. This gets us to a next question, that is question 50. This gets us to 50. Unfavorable prognostic factor in neuroblastoma. Triploidy or hyperploidy or DNA ploidy is good prognosis. N-MYC amplification. Firstly, the most common gene mutation associated with neuroblastoma, N-MYC amplification, which is poor prognosis. And last is tyrosine kinase receptor inactivation, again good prognosis. So the answer to question 50 is C, that is N-MYC amplification. Answer is C, that is N-MYC amplification. Let us make the master table of good prognosis versus poor prognosis in neuroblastoma. Let us have a look at the master table. First point, age. Age less than 18 months is good prognosis versus more than 18 months, which is poor prognosis. Next point, maturity. Maturity component. What do we mean by maturity component microscopically? It is the presence of gangliocytic differentiation. Maturity component, that is gangliocytic differentiation and Schwanninian stroma. Gangliocytic differentiation and Schwanninian stroma. If it is present, it is good prognosis versus absent, which is poor prognosis. More mature is the tumor, better is the prognosis. Next is mitosis. Low mitosis is obviously good prognosis, whereas high mitosis is poor prognosis. Next, mutations. Now we have already seen that the most common mutation is N-MYC amplification. Most common is N-MYC amplification. If it is present, it is poor prognosis versus absent, which is good prognosis, Next is chromosome 11 and 17 mutations. Again, if present is poor prognosis, whereas absent is good prognosis. So mutations if present is poor prognosis, absent is good prognosis. The only exception to this rule is TRK expression. If this is present, it is good prognosis versus absent, which is poor prognosis. And the last is Turk B expression. Turk B expression, which follows the general rule, that is present is good prognosis, present is poor prognosis, absent is good prognosis. So Turk A expression was the only exception. DNA ploidies or DNA hyperploidies is again associated with good prognosis. DNA hyperploidies are associated with good prognosis. These are the prognostic factors in neuroblastoma. So the answer is NMIC amplification. Next, this gets us to a next question, that is question 51. This gets us to a next one, that is, just let me give a sec to this. Question 51. First point, let us have a look at the question. Solitary fibrous tumor of the pleura is associated with, and the answer is CD34 positive. Now there are two important points in this. Fibrous tumors of the pleura, I had not expected you to know that they are 34 positive, but you know that asbestos exposure is associated with mesothelioma. So what you are left with are only options A and B, and it is 34 positive. If you had to hit a fluke between the two, you should have gone for A, that is solitary fibrous tumors of the pleura. They are CD34 positive. Just a sec guys, I guess my laptop is giving some issues today. Next, so let us have a look at slight more detailed look at solitary fibrous tumors. Solitary fibrous tumors. These were earlier called as benign mesotheliomas. These are benign mesotheliomas, but this term is obsolete now. That is, it is not used. Now when we say it is mesothelioma, we mean malignant mesothelioma, which is asbestos exposure. Next point, these are CD34 positive, keratin positive. They are not keratin negative, keratin positive, and have no relation with asbestos exposure. No relation with asbestos exposure. This is solitary fibrous tumor. Next, this gets us to the next question, that is question 52. Question 52. Single most important prognostic factor in colorectal cancer, and the answer is stage. But as a general rule, histological type and grading is okay, but the most significant, that is we look at TNM, tumor node metastasis. The answer is stage A, that is stage of the tumor. Next, I don't think any of you would have gone wrong in that. Next, one cell thick pattern of tumor cells is associated with, and the answer is invasive lobular carcinoma breast. The answer is D, that is invasive lobular carcinoma breast. Let us have a slight more look at invasive lobular carcinomas. First point, invasive lobular carcinomas, they are predominantly bilateral in nature. Next, microscopically, they are associated with E-cadherin mutation. Microscopically, they are associated with E-cadherin mutation, which gives it the presence of discohesive cells. That is, the cells, they are present singly scattered, and this appearance is called as Indian file appearance. This appearance is called as the Indian file appearance. So this was the question, that they are present singly scattered. I'll show you what they microscopically look like. Next point, if they are singly scattered, desmoplasia or desmoplastic response. What is desmoplasia? It is fibrosis occurring in response to the tumor. Is it present or absent? This is absent because they are singly scattered, so fibrosis in response to the tumor will not take place. So invasive lobular carcinomas, they are non-palpable in nature. Next, they are not detected by mammography also. They are not, the tumor is not associated with calcifications, so it is not detected by mammography. As a result, it was non-palpable, not detected by mammography, so it is the most common cause of occult primary, in the breast. This is occult primary, means the tumor has spread to the lymph nodes, but we do not know the primary. Of course, in an elderly female, first thing we'll do is examine the breast for breast cancer. So this is invasive lobular carcinoma. And microscopically, this is what it looks like. You have the presence of single cells which are present in a single lined linear fashion. Invasive lobular carcinoma. Next point. This gets us to a next question, that is question number 54. Question 54. Key difference between mycosis fungoides and Sézary syndrome. Firstly, बच्चे, mycosis fungoides and Sézary, these are the two main cutaneous T cell lymphomas. Main difference between the two are the clinical stages. Now, let me write this for you. Question 54. Question 54, the answer is B, that is the 3 clinical stages. Now, before we go further, we have already seen that mycosis fungoides and Sézary syndrome, these are the two cutaneous T cell lymphomas. These are the two cutaneous T cell lymphomas, and microscopically they are associated with the presence of characteristic cerebriform nuclei. They are associated with the characteristic cerebriform nuclei called as Sézary cells. They are characterized by cells with brain-like or cerebriform nuclei called as the Sézary cells. Have a look at this image. What you see here, it is a peripheral smear, RBCs in the background with brain-like cells, the Sézary cells. Next, so coming to the question, they have the cerebriform nuclei, follow an indolent course, and it is a tumor of T cells, CD4 helper T cells. So the answer by exclusion is B. Next, peripheral smear is showing cells with arrows. Diagnosis. What you have here, see, majority of the cells, they are the RBCs with the central 1/3 pallor. Now look at these two cells which are different. They lack the central pallor. So diagnosis, these are spherocytes. These are the spherocytes associated with autoimmune hemolytic anemia. So question 55. The microscopy was showing you the presence of spherocytes because they lacked the central pallor. They lacked the central 1/3 pallor. Next point, spherocytes, they are seen in two hemolytic anemias, hereditary spherocytosis and autoimmune hemolytic anemia. So the answer is A, that is autoimmune hemolytic anemia. Next, this gets us to our next one, that is question 56. HIV is associated morphologically by. Now, firstly, it is a subtype of FSGS. What is the fancy name of variant of FSGS? Before we go to HIV and the question, you know FSGS, focal segmental glomerulosclerosis, has numerous causes. The initiating cause was reduction in renal mass. So the causes of FSGS are hypertension, hepatitis B, HIV. Hypertension, hepatitis B, HIV. Alport syndrome, reflux nephropathy, Alport syndrome, reflux nephropathy, and heroin intake. Alport syndrome, reflux nephropathy, and heroin intake. Next, it is also associated with NPHS 1 and 2 mutations. Today in our discussion, I am not getting into NPHS 1 and 2. Now, out of these, which is the worst prognostic FSGS? The one associated with HIV. And this has a fancy name to it called as collapsing glomerulopathy. This has a fancy name to it called as collapsing glomerulopathy. Easy to remember, the patient went to have some fun but his whole world collapsed around him. Collapsing glomerulopathy, which is the worst prognostic FSGS. Which is the worst prognostic FSGS. This is your baseline knowledge. So now let us have a look at the question. What you have here is HIV associated nephropathy, collapsing variant, agreed. Now if everything is collapsing, there is focal dilatation of tubule segments with proteinaceous material and large inclusions within endothelial cells. But all the points are true. In this, the only confusion in the option was either 1 or 4. Second and third look okay. Even if you were not aware of that microscopically, they look okay. This is what you will always have to hit out even in the answers in the NEET exam. So the answer is D, that is all of the above. The answer is D, that is all of the above. Next point, this gets us to a next question, that is question 57. Which of the following is maximally associated with hyperviscosity? Hyperviscosity syndrome, multiple myeloma, classically IgM. This is a fact. Question 57. The answer is A, that is IgM. The answer is A, that is IgM. Next point, let us have a look at what we mean by hyperviscosity. देखो बच्चे, the normal serum viscosity, the normal relative serum viscosity for that matter, viscosity is 1.8. 1.8. What are we comparing it with? Water. So that means that the serum is approximately 2 times or exactly 1.8 times as thick as water. Next point, multiple myeloma is associated with hyperviscosity. There is increased serum viscosity, most commonly with IgM, followed by IgG3 and IgA. This is a fact. Next, this gets us to our next question, that is question 58. Now, raised ALP with absence of aminotransferases and normal bilirubin. Just ALP is increased, bilirubin is normal. It is seen in all amyloidosis, CCF and diabetes. ALP is increased in all. So this is more of a medicine question, but I am again okay with the fact that majority would have gone right in this. Next, question 59. Which is false about cystic fibrosis? It is autosomal recessive, cystic fibrosis, autosomal recessive. Which subtype or which chromosome? Chromosome 7. So option 1 is okay. Associated with misfolding of proteins and the gene is 7q. That's okay. Now, defect in the respiratory tract is decreased sodium. No, the defect in respiratory tract is increased sodium absorption. Question 59. Answer is D. Defect in respiratory tract. Defect in respiratory tract is decreased sodium. This is false. It is not decreased, it is increased sodium absorption. Let us have a look at this. In the respiratory tract, normally there are 2 proteins, that is CFTR and ENaC. CFTR protein and ENaC. The normal role of CFTR protein in the respiratory tract is excretion of chloride into the lumen, and the normal role of ENaC is absorption of sodium from the lumen. This is normal. This is normal. Next point, in the respiratory tract, CFTR gene downregulates ENaC. In the respiratory tract, CFTR gene downregulates ENaC. So, in cystic fibrosis, if this is the cell, let me draw this again. If this is the cell with again the same two proteins, CFTR protein and ENaC. CFTR, let me draw the cell slightly in a better manner. CFTR protein and ENaC. In cystic fibrosis, the activity of CFTR protein is reduced, as a result of which the secretion of chloride reduces. So more chloride is present in the cell. And ENaC, CFTR gene downregulates ENaC. So if the CFTR gene is mutated, the downregulation is less. That is, the activity of ENaC increases. So more sodium is present inside the cell. This is cystic fibrosis, as a result of which the mucus which is present in the lumen becomes dehydrated to maintain osmolarity. Water enters into the cell. This is cystic fibrosis. So, in cystic fibrosis, the defect in respiratory tract is increased sodium absorption, not reduced. It is increased sodium absorption. Next, this gets us to a next question, that is question 60. This gets us to question number 60. Which of the following is associated with hepatitis C? And the answer is A, that is anti-LKM1, anti-liver kidney microsome 1 antibody, anti-LKM1. Let us have a look at this in slight more detail. Anti-LKM1 antibody, it is associated with hepatitis C, autoimmune hepatitis, and of course we have written the chronic hepatitis, most common cause being hepatitis C. Next, anti-LKM2 antibody is associated with drug-induced hepatitis. It is associated with drug-induced hepatitis versus anti-LKM3 antibody, which is with chronic hepatitis D virus. So LKM 1, 2, 3. 1 hepatitis C, autoimmune. 2 drug-induced hepatitis, whereas 3 is with chronic hepatitis D virus. Next, this gets us to a next question, that is question 61. Now, again, there's a long history, 65 worsening, CRF, hemodialysis, ultrasound shows this, that. Not needed, bache, not needed. Just have a look at the gross image. What this shows you is the presence of numerous cysts in the kidney, with presence of a bosselated outer surface. The outer surface of the kidney is bosselated, and the cysts are present randomly in cortex and medulla. This is the classical gross of adult polycystic kidney disease. This is the classical gross specimen of adult PKD versus childhood polycystic kidney disease, in which it has a smooth outer surface and cysts are at right angles to the renal capsule. So now, adult polycystic kidney disease, it is autosomal recessive or dominant? Autosomal dominant. So the answer is 4. The answer is 4, that is dominant polycystic kidney disease. Next, let us have a look at few points with adult PKD. It is a progressive renal disease. Progressive means it leads to chronic renal failure. It leads to chronic renal failure in 5th to 6th decade of life. It leads to chronic renal failure in 5th to 6th decade of life. Next point, in this, the chromosomes affected are 16 and 4. The gene abnormality is PKD1 and 2 with the abnormal protein being polycystin. So you know the chromosomes, you know the genes, you know the protein associated. This is adult PKD. Next, this gets us to our next question, that is, just a sec guys, this gets us to our next question, that is question 62. Question 62. First, let us have a look at the question again. Biopsy of small intestine with foamy macrophages. The minute you have the presence of small intestine foamy macrophages, the answer is 1, that is Whipple's disease. The answer is A, that is Whipple's disease. Whipple's disease microscopically shows the presence of PAS positive diastase resistant granules. PAS positive diastase resistant granules where in macrophages and the most common location of these macrophages is lamina propria. Bache has to be remembered. Biopsy in Whipple's disease is diagnostic. It presents as a diagnostic biopsy. This particular point has been asked repeatedly, and this is what Whipple's disease looks like. You have the presence of all these cells which are present in the lamina propria, the ones I am showing with the arrow. You are able to make out that these have pinkish granules in the cytoplasm. PAS positive diastase resistant granules, Whipple's. Next, this gets us to our next question, that is question 63. Which plays a role in gene editing? Gene editing, CRISPR gene. The answer is B, question 63. The answer is B, that is CRISPR gene. That is CRISPR. CRISPR, we have discussed this numerous times already. It is CRISPR-Cas9 is a gene editing tool. CRISPR-Cas9, this is a gene or a genome editing tool. This is a genome editing tool and is essential for adaptive immunity and is essential for adaptive immunity. It is essential for adaptive immunity to play a role against microbial infections. This is CRISPR. Next point, in this, though the repair is done by, in CRISPR, the repair is done by two techniques. The genome editing or the repair, it is done by two techniques, that is NHEJ, which is non-homologous, NHEJ, non-homologous end joining, NHEJ, non-homologous end joining, and homologous recombinations. And homologous, the repair is done by two techniques, NHEJ, non-homologous end joining, and homologous recombinations. NHEJ, non-homologous end joining, this is for mutations, whereas homologous recombinations is to introduce new sequences. This is to introduce new sequences. This is CRISPR. CRISPR-Cas9, this is a genome editing tool. Next, this gets us to our next question, that is question 64. This gets us to the next one. Which of the following is used to describe the state which is encircled? This bache is the classical schistocyte. I need not even explain this. This is a fragmented RBC or a schistocyte. This is a schistocyte. Okay, so this gets us to question 65. Now what we see here is, it is surgery in scrotum tumor specimen. What you see here is a well demarcated tumor. It has fixed boundaries, it is well demarcated, homogeneous tumor, soft. This is the classical description of seminoma. So question 65, the answer is A, that is seminoma, which grossly are soft, well demarcated, gray white tumors, soft, well demarcated gray white tumors, which bulge from the cut surface, which bulge from the cut surface of the testis, which bulge from the cut surface of the testis. This is seminoma. Next, this gets us to the next question, that is question 66. Sorry. Now 20-year-old girl, soft nodule seen in chest, not increasing in size. Diagnosis. Now this is a reddish nodule which is present on the chest of the girl. Microscopically, which is associated with, I'll slightly enlarge the image, which is associated with the presence of numerous capillaries. We are able to see this. This is not a lipoma. There are very few fat cells in this. This is not a lipoma. Lipoma would have shown you abundant fat cells. Of course, this is not Paget's disease. Paget shows you the presence of large cells which are present in the skin or the nipple of the female. So Paget's and lipoma is absolutely out. The answer is A, that is hemangioma. The answer is A, that is hemangioma. Hemangiomas, they are one of the most common tumors. They are the most common tumors of infancy. And in children, they are located in the skin, particularly of face and scalp. Grossly, they present as red elevated lesions. Grossly, they present as flat to elevated red-blue masses, red-blue irregular masses, flat to elevated red-blue irregular masses. Microscopically, it is associated with the presence of numerous capillaries, and of course it is associated with Sturge's syndrome and stuff. It is familial. Let me read it for you. They are familial. They can be associated with familial syndromes like von Hippel-Lindau, VHL, von Hippel-Lindau syndrome, cerebral hemangiomas, and Sturge-Weber syndrome. Von Hippel-Lindau and Sturge-Weber syndrome. This is hemangioma. Just a sec, guys. This was question 66. Next, this gets us to our last grand test question in pathology, that is question 67. Eczematous reaction 72 hours after wearing latex gloves. Classically written as 3 days after the response. So the answer is 4. It is a delayed type. Question 67. The answer is 4. That is, it is type 4. It is type 4 or a delayed type of hypersensitivity reaction. Nothing, I guess, to explain in this. Done. This finishes your pathology discussion for grand test 179. In case you have any queries whatsoever, you can simply mail them to me at sushantsoni@gmail.com. gmail.com. My name is Sushant Soni, so there's an extra S in the email. Done. Take care and bestest of luck.